Thank you for introducing my talk, actually. So I'm not going to repeat what has been largely said by the previous speakers, the overdiagnosis of significant tumors, I think you have understood now, and the underestimation also of aggressive tumor in approximately 30% of the cases, particularly when they are anteriorly located. So increase the number of cores with the limitations it includes, as very well presented by Bob Javan, with maybe he didn't insist enough, according to me, to the increasing rate of complications induced by the increase of the number of cores. And the alternative, of course, is a pre-biopsy multiparametric MRI, which provides an excellent tumor visibility and allows for MR in-bore guided biopsies, as presented by Bernd, and also allows for MR truss image registration, fusion. So fusion, three modes. There's three modes of image registration. The cognitive, which is used actually by a massive majority of urologists or physicians now, and software-assisted registration with two kinds of registration: the non-deformable or rigid, which doesn't take into account the deformation of the prostate contour, and the deformable, which is an elastic registration, and I present both techniques. The cognitive registration is a very simple problem. If your brain is very good, if you're very familiar with MR, and you can see that you don't need to be very familiar with MR. The target is obvious anteriorly here, but the day of the biopsy, you need some help, because you just don't see the anterior lesions like these ones. So you need a document, or you need a screen connected to the workstation, so that the physician who does the biopsy with his brain can direct the target this anterior portion of the prostate. And that's what do most of the urologists at the moment. Intuitively, the accuracy of this technique may decrease with the depth of the lesion, that is, with anterior located tumors and/or with the prostate volume. So the second widely used technique is the non-deformable image fusion. It's basically all based on a navigation system, which localizes the probe. It tracks the probe, and only the probe. It doesn't track the organ. It tracks the probe. You have it in your hand. It's and this is the transmitter, which creates a magnetic field around the patient. This is the receiver, which is connected on the probe, and of course, as any GPS, it just tracks the probe. So the planning phase is just first to display on a pre-biopsy MRI the target here and then you load the images within the truss machine, as shown by Bernd. This is the planning phase, and during the planning phase, you have to make sure that you overlay both organs. So you use internal markers, you use the prostate contour. Here you see this area on the right side, which is bright on T2, corresponding to the hyperechoic area here. In the middle of the prostate, you have the urethra. On the left side, you have this nodule, and posteriorly, you can see that both prostate contour do not overlay consistently, because the deformation of the prostate by the truss probe is not the deformation of the posterior aspect of the prostate by the MR probe. And if you don't use any erectile probe for the MR, the deformation is on the way. So you have still approximate overlay of both of the organ on both technique. But well, you can be satisfied. And then when you activate, you see that these tiny cysts can be overlaid with this tiny cyst, and this large. Okay, you're satisfied with the overlay because you can just see that the internal landmarks can be overlaid during scanning, and then you can do the biopsy. as shown by Burns. The target is virtual because you don't see or barely see it on truss, and you activate the biopsy again to sample the prostate. It can be done also in large anterior lesions, which can be obvious here. It's obvious lesion on MR, and which retrospectively can be seen on truss, and then you activate in the same manner. Just you overlay first, then you're satisfied with the overlay because the contour is okay. The posterior aspect of the prostate is also well overlaid, and then you activate the GPS, and you can biopsy with confidently. The only problem of these techniques, as said by Burns, is the fact that prostate moves. It moves all the time. When you scan the prostate with a truss probe, you can't imagine how much the prostate can move. It just moves anteriorly, so it undoes the registration all the time. So very often you have to redo it and again to redo it. So the less you move, the better the registration. And the patient also has to be, patient immobility is critical. And so this is illustrated in this also. A non-deformable registration, 3 points or internal markers, same thing on truss, and then when you overlay, of course, the contour and the shape of the prostate is not the same. So the accuracy is approximately 5 to 10 millimeter, according to the literature. Deformable means that you place a number of other points, thousands of points all over the surface of the prostate. Then the same on truss because you use the same tool. Then you overlay rigid, but now you have an elastic deformation, so that the contour of the two organs fit accurately. And the accuracy of such a technique is probably much higher. An example, the planning phase of truss image registration with the elastic deformation. Here is the lesion anteriorly located. It's dark. Okay, it's dark. It's bright on diffusion. It's hypervascular. So the first part of the registration consists of applying a mesh of thousands of points based on it's a statistical shape mesh, and then you adjust the mesh so that it fits the contour of the prostate by placing a couple of points. You do the same thing with truss, but you need a motorized 3D truss, a true 3D acquisition, and then the mesh is again applied to the prostate shape contour, and you adjust it with a couple of points. So you deform this mesh so that it can be accurately applied to the prostate contour. And then you place a region of interest, because you see it very easily on T2 or on diffusion, and then you activate the fusion. And this is after the end of the planing phase, you obtain a geometric elastic fusion between the MR contour, which have been deformed to match exactly the contour of the truss image. And the target looks like a yellow tag. It can be displayed either on truss, indifferently on truss, on MR. And the targeting error of such a fusion has been evaluated in a phantom study. It's approximately 2 millimeter. Now, you're not finished. This is the reference volume you just acquired. But now you're going to do the biopsy. Before each biopsy, you need an acquisition. So this is the acquired volume on the right side. Before each biopsy, registration is very poor. So you need to do a truss registration. And now you start with 2 steps, 2 rigid steps. Look, they're going to adjust the anterior part of the bladder. It starts well, but the posterior aspect is still not adjusted. So you use a new and a second deformable registration based on a voxel iconic fusion. And now the posterior aspect of the prostate is going to be adjusted. And now the acquired volume is perfectly adjusted to the reference volume. And because the reference volume is registered to the MR, you are in the good condition to start the guiding phase of the biopsy. So this is the acquired volume. So you aim the presumed area, you activate the biopsy gun, and if you're good, the needle is within the lesion, and it can be displayed on truss or MR. This is not a real-time technique. This is the only limitation of the technique. But 3 biopsies can be enough to diagnose this anterior lesion Gleason score 4+3. Now, sometimes the lesion is less conspicuous, especially on T2. It's all gray. It's better seen on diffusion, so you might use diffusion or T2. Both sequences can be used. But before you aim exactly the lesion, you make a first guess. You just aim and activate. You don't activate the biopsy gun, and you have a virtual biopsy. So you're not good. Another trial, you're not good. You're getting better, but you have to adjust to have the 3 cores within the lesion. And in some selected cases, you may also be helped by the diffusion, either because you better see the lesion on diffusion than on T2, which is common, or because you want to target the darkest portion of the ADC map to try to pick up the high grade of the lesion. This has not been validated yet. And it can also work whatever the size of the lesion. This is probably one of the smallest tumor we could pick up, but this technique, highly anteriorly located, detected by diffusion, and then retrospectively seen on T2, and 3 negative of negative biopsies, and this could be the same technique was applied, and 3 positive cores of 2, 6, and 4 millimeters could be obtained from this tiny lesion anteriorly located. So all the papers show that targeted versus sextant have a better accuracy. They increase the cancer detection rate, especially in high pyrite score lesions, 4 or 5. It also detects the high grade, the high grade cancer detection rate by approximately 40%. So they contribute to detect only significant cancer, and also they decrease the detection rate of insignificant cancer. So the problem is which is good? Are we better with the machine? The software is the software better than our brain to target the lesion? One study showed that cognitive registration was significantly performs less well than rigid registration, but the study was critical because it was 2 consecutive series of patients. The patient was not his own reference. So these results may be less valid than the 2 prospective studies of the 2013 reported in 2013, where 2 operators compared cognitive versus rigid registration biopsy technique, and showed that the brain performed and the machine performed equally. But more recent studies reported by Portales and our group may show that cognitive registration is definitely less effective than elastic registration. This is the prospective study. MR reading was done in consensus by urologists and radiologists. The test was intended to evaluate the performance of urologists to know if they could do as well with cognitive and then with targeted. And there was only one operator, urologist, familiar with sextant biopsies. The patient was his self-reference, so he had first 2 cognitive biopsies. The targets were blinded, but the machine can register the location of the biopsies, and then it was compared to 2 biopsies done with the elastic registration, and then the two sets of biopsy could be compared. And the results were that there were significant differences concerning with regard to the mean distance to the center of the target. It was 10 with cognitive course versus 5 with MR targeted. With regard also to the mean distance to the envelope of the target, which was 6 millimeter with cognitive course versus 1.3 with MR guided. And concerning the cancer detection rate, which was 40% with cognitive course versus 50% with the image-guided course. So the conclusion of all this is that all this relies on the definition of a target. That's probably the main topic. And the PIRA score is done. It's been very well presented by one of the previous speakers. And maybe its discussion is open. Should we include the score 3, or should we just do biopsies to the score 4 or 5? It can be discussed in the. It can be. We can talk about that in the discussion. And the rationale for an elastic or deformable fusion. At the moment, Coalesce is the only company which provide that. Other companies which provide is that it definitely tracks the prostate. The prostate moves. Don't worry. You can remove the probe, and at any time during the biopsy procedure, you can put the probe again. You just track the prostate. Come back. You move. I will pick you back and register you to my reference volume. Also, the patients can move, so it's not a real-time technique, which is the main limitation, but it's according to what I've done for 5 years now, starting with the navigation system, and now using the elastic registration. Definitely, conceptually, the elastic deformation with organ tracking is the true MR truss fusion technique which should be used in the future. Thank you.
Okay, thank you.